Good evening, everybody. Welcome. My name is Roxanne Chabot from RBC Consultants. This evening, we're going to explore strategies to treat acne and avoid antibiotic resistance. As speaker this evening, we have Dr. Charles Lind. Dr. Lind is Chief Medical Director at the Lind Institute for Dermatology and Lind-Derm Research, as well as Associate Professor at the University of Toronto Department of Medicine. We also have Dr. Lynn Gunther, Professor of Dermatology, Western University, and President of Gunther Research. We'd like to thank our sponsors, Cypher, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to ask a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. Within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be sent to you by email. Again, if you want to submit questions to our faculty, please type in your question in the question chat pane on the right-hand side of your screen. And I wrote a little note there so you could see where you need to type in your questions. The opinions expressed in this presentations are that of the presenters. They do not necessarily reflect the opinions of Cypher Pharmaceutical. So without further ado, I will pass the floor virtually to Dr. Charles Lind.
Thank you very much, Roxanne. Just to let you know, I've been a speaker, consultant, and principal investigator for essentially all companies and that do research, because I'm doing a lot of research with different drugs in dermatology. So we're going to talk tonight about acne, and this is something I think we all see in our offices. We see acne in various grades, as you can see here. We know that it's a very common problem, affecting about 2 million Canadians, all age groups, but obviously those in the teenage and younger groups are the more common. It has an emotional and social impact and can be quite significant. And one of the things I've been practicing a number of years, we used to see acne vulgaris that had actually gram-negative folliculitis or gram-negative acne because we overused antibiotics for many years. This paradigm has certainly shifted over the last several years. This is just a little algorithm of the management of acne, clinical practice that was in the CMAJ. I was part of this. And basically one of the things that was in here, again, try to limit your potential for producing bacterial resistance by using antibiotics for a short period, such as 2 to 3 months only, and not continue like we used to over many months or years. Much like climate control, there are believers and non-believers. So there are a number of people that say, oh, use as many antibiotics as you want. It really doesn't matter. Use it because you're going to make that patient better. And obviously, it's much like the climate control. There are people that say, deniers that say climate change is not a problem. I'm here tonight to set the stage and say excessive antibiotics are a problem and a problem around the world. We'll start with this polling question. And the polling question really saying, do you have a concern with antibiotic overuse in acne? And just answer yes or no. You can tell already what I'm thinking, but I'd be interested to see, though, maybe we have some people on the line that say, no, it's not a problem. So please vote. Oh, well, we don't have much, Dr. Gunther, you won't have much problem here. We only have to convert 10% of people or so. All right, now the next polling question. Roxanne, will you put this up? I think there was another polling question, was there not?
Yep, it's open now.
Here's the next polling question. Which of the following is not associated with bacterial resistance? Antibiotic monotherapy, i.e. without any topical benzoyl peroxides, etc. Long-term antibiotic treatment for greater than 12 weeks, i.e. greater than 3 months. Dosing of antibiotics below their recommended levels. Simultaneous use of chemically different antibiotics. And single short-term antibiotic courses. Please vote. All right. Yeah, the answer is number last one. But in fact, even single short-term antibiotic use, because of the sheer volumes of antibiotics that we're using in Canada or elsewhere in the world, potentially can cause a problem. That's the one that was designed as being the correct answer. All the others will increase bacterial resistance. So I just wanted to put, it is a worldwide problem. It's not just in Canada. It's maybe a little bit hard to see on this little map of the world here, but in the United States, over 90,000 deaths per year attributable to infections in hospitals. And healthcare costs because of antibiotic or antimicrobial resistance bacteria is somewhere between 20 to 34 billion dollars per year. Similarly, in South America, a greater than 50% of hospital infections are caused by antimicrobial resistance. Brazil, similarly, greater than 60%. Europe, similarly, big dollar values, again, 150 billion euros per year, and again, 600 million days of lost productivity because of this problem. Russia, you can get antibiotics at any corner store. And again, you can see that it's a major concern because over 80% of families just use antibiotics whenever. You got a bit of a sore toenail, you got a sore throat, you're feeling like you got some stomach problems, just take some antibiotics. And you can see the figures around the world show you that this is a worldwide problem, increased resistance, and we don't have a lot of new antibiotics coming online that can look after a number of the diseases, even Staph aureus. You can see also in Antarctica, these antimicrobial resistant bacteria have actually been found in the water sources there. So it's all over the world. This is just a little table, again, just showing you antibiotic resistance and acne therapy, worldwide problem. You can see the isolates in Spain, and 90% roughly are resistant to topical clindamycin and erythromycin. United States is a little bit lower, around 80%. You can see the figures all over the world. This is a problem. We see resistance to the drugs that we used to use. And I can remember early on in my career, we used topical clindamycin almost like it was water. Topical erythromycin, almost like it was water. The thinking around this has changed drastically because one, we want our patients to get better, and we know that this is a problem. And it's a problem that's going into other, not just acne, but other antibiotics and other problems and other things that we might want to be treating. Historical perspective, the last 30 so years have shown an alarming increase. This is the figures from this particular publication. 1978, again, incidence of P. acnes, antibiotic resistance jumped from 20% to 62% in that sort of 30-year time period. And again, these strains have been shown to emerge after only 8 weeks of topical antibiotic monotherapy. Oops, sorry, gotta go backwards here. Tricky computer. So again, there's certainly, as I was alluding to this, clinical relevance, okay? Certainly potential increase in the pathogenicity of C. acnes can occur. Reduce clinical response to our antibiotic therapy that we might want to be using for the acne. But the biggest problem is there's a transfer of those resistance to more pathogenic organisms that may be in the body, such as Staph aureus. So this is really concerning, eh? So when you get antibiotic-resistant staph epidermidis, this drug resistance can be transferred to other bacteria. They kind of quotation marks sleep together. And these coagulates negative staphylococci to this staph aureus with increasing multiple drug resistance. And again, this shows decreased clinical response. This was a review of about 50 clinical trials between 1974 and 2003, showed a significant decrease in the efficacy of topical erythromycin. And that's really why erythromycin isn't available anymore. It just doesn't work. People were finding there were such high numbers of resistance that when you gave it for any of the conditions, you weren't getting a benefit. So we got another polling question here.
Actually, Dr. Lynn, we already did it. We kind of jumped the gun there.
All right, okay, that's fine. So factors contributing to P. acnes resistance. Again, we talked about this: antibiotic monotherapy, long-term treatment, indiscriminate appropriate use of antibiotics, dosing of antibiotics below those recommended levels, simultaneous use of chemically different antibiotics, poor adherence, and multiple antibiotic courses in the person. These are a number of the antibiotics that we use, and certainly I think that dermatologists probably overuse antibiotics, particularly the oral antibiotics. We use tetracyclines, doxycycline, minocyclines, erythromycin, azithromycin, clindamycin, and trimethoprim. And again, as I mentioned earlier, really one of the strategies, and Dr. Gunther is going to go into this, is that oral antibiotics should ideally be used for less than 3 months. And again, rethink antibiotics before you prescribe it. Again, you might decide to use it topically or systemically, but certainly topicals increase the concentration without candidiasis or GI upset, but they also increase the antibiotic resistance to C. acnes. And as I mentioned, antibiotic resistance is very high to erythromycin and clindamycin, and it can be found in orals, even such as minocycline and tetracycline. So we should work to avoid antibiotics in most cases, particularly long-term. I think because we are such large overusers of antibiotics, we should be good stewards of this overuse and recognize the implications of bacterial resistance, not only for our patients, but also for the good of society when these mutate and cause other organisms then to become resistant. And then we don't have drugs to actually treat some of the common problems with, such as with Staph aureus. So I'm going to pass the floor over to my good friend, Dr. Lynn Gunther, who, as you heard, is professor of dermatology at Western University. Lynn, like I do, has a large clinical research unit. She's an excellent speaker, and she's going to talk about really the strategies. I've told you that basically we have a problem, but what do we do as clinicians to solve that problem? How should we think of other drugs that may make it so we don't have to use as many antibiotics? Lynn, take it away.
Thanks, Chuck. So these are my disclosures, very similar to Chuck, but I'm also, for several years, I've been medical editor in Canada for Dermatology Times of Canada, and something new that just came out I will be presenting towards the end of my presentation. There's actually a lot of new things that have recently come out, so you are listening at a very good time because we have lots of new information for you. So let's have a polling question. For what percentage of your acne patients have you ever prescribed an oral antibiotic? That doesn't mean you have them continuously on it, but just that you gave them an antibiotic at one visit. Okay, so we have quite a few, some 5%, almost all. So we'll give you some different strategies, hopefully by the end of tonight. And we have fairly high numbers, and only 5% was none. So What is in our toolbox? Well, if you look at the rainbow and what we have topicals, we have systemic antibiotics, which you've heard we want to limit. We have anti-androgens and some new ones coming. We have lasers and some interesting information on biofilm busting activity. And finally, our go-to, very potent, still remaining potent after almost 40 years, it's still the only drug that can put acne in remission. So when we're looking at acne treatment, we have to have goals when we've got our patients. And I think when we're looking at picking a treatment, you have to have a target. So we want to target all, if possible, or as many as possible, of the pathogenesis in acne. And as you're well aware from Dr. Lynn's presentation, you can get antibiotic resistance not just with oral, but with topical as well. So let's look at how various treatments work. When you look at benzoyl peroxide, and retinoids and salicylic acid, azelaic acid in the US is approved 20% to treat acne. We have the 15% phenacia, which actually works fairly well for acne, but it is considered off-label in Canada. And topical antibiotics and oral antibiotics really don't do anything for sebum production. When we look at altered keratin, all of the drugs except for the antibiotics work for altering keratinization. And you can see these C. acnes proliferation and inflammation. But what I want to point out is the only drug that can put it into a permanent or a very prolonged remission remains isotretinoin, even after 40 years of use. And this is just to show you how it targets sebum production, altered keratinization, C. acnes proliferation, as well as inflammation. So let's look at the topicals a little more closely. What do we have in our toolbox? We have retinoids, we have benzoyl peroxide, we have antibiotics, we have dapsone, which is marketed as Axone. We have combinations of the above, and azelaic acid, which would be used off-label in Canada. So retinoids, what exactly do they do? They're a derivative of vitamin A. They normalize follicular desquamation. They also decrease inflammation. So even though they can cause some irritancy, they decrease inflammation. When we look at benzoyl peroxide, it actually kills bacteria, so you don't get antibiotic resistance. And that's why we're using it with topical and oral antibiotics to try to minimize resistance. It improves follicular desquamation, it decreases the acnes, and this ultimately results in decreased inflammation, and again, no antibiotic resistance. It can decrease the antibiotic resistance when you use it with topical as well as oral antibiotics, but it also increases efficacy, so it is synergistic. Now, antibiotics I put in red because really we're trying to limit antibiotic resistance. So if you're using them as monotherapy, and there still is topical clindamycin available as a monotherapy, then I think you're potentially asking for trouble and antibiotic resistance. So we would urge you not to just use the monotherapy. So what do we have available? We've got actually quite a lot of retinoids, and today I just received a fax saying that Araslo, which is basically Duabri without the steroid, so it has just tazarotene in a very nice moisturizing base, it is now available in Canada. And another new one that came to Canada was Acleaf about a year ago. We also have various formulations of benzoyl peroxide. Azelaic acid is considered off use, as I mentioned before. We have the topical dapsone, and I would urge you not to consider using Dalacin T and Clinda T because they are monotherapy and associated with antibiotic resistance. So let's look at some more topical agents that we have. We have azelaic acid. It is safe in pregnancy, so if you're looking for something to give your pregnant women, this is something you can give them. It also decreases post-inflammatory hyperpigmentation. Antibiotic resistance is not a problem, so this is something to be aware of. Now, there was a Cochrane review looking at azelaic acid, and it was felt that it was probably less effective than benzoyl peroxide, but similar efficacy to tretinoin. And finally, we have dapsone, which is antibacterial, but we don't have C. acnes resistance to dapsone. So it decreases C. acnes, thereby decreasing inflammation. There are a number of combination products. So those with benzoyl peroxide, as you can see, the top and the bottom one, you don't get antibiotic resistance because benzoyl peroxide is bactericidal and prevents the resistance from occurring. Now, when you're looking at by Acne, they did a 16-week trial and they did not see antibiotic resistance during those 16 weeks, but the retinoid does not. It is felt that the retinoid allowed the clindamycin to penetrate much more readily, so therefore it was able to get rid of the C. acnes more effectively. But with long-term use, I would think that there might be a potential for antibiotic resistance. So I think the BPO versions are probably safer when you're trying to limit antibiotic resistance. So I think we want to use topical retinoids and benzoyl peroxide as first line. Do not use, or I really would caution you not to use antibiotics as monotherapy. If you are going to use them with benzoyl peroxide and a retinoid. When you're using them with these products, they actually decrease the irritation that you can get with a retinoid and the irritation you can get with benzoyl peroxide. So it makes the product more tolerable. All strains are sensitive, and when you're looking at maintenance therapy, by the global group for acne, topical retinoids, benzoyl peroxide, or azelaic acid were felt to be the best maintenance therapies. So systemic antibiotics, what do we have? What can we do? They work not just by cutting down on C. acnes, but they also have anti-inflammatory properties. When you think of rosacea and antibiotics, they are working primarily through inflammation. The same thing can occur in Acne Vulgaris. But the Global Alliance, again, just like Dr. Lind and I have stated, try to avoid them when you have other alternatives. When might you actually consider an oral? So if you've tried a number of things and the inflammatory acne is not responding, then you perhaps have to use an oral antibiotic. Try to limit it to 3 to 4 months, not to use it as monotherapy. Do consider using benzoyl peroxide with it. And there have been some studies looking at subantimicrobial dose antibiotics, and such as doxycycline 40 milligrams. And there was one study where it showed that it had comparable efficacy to doxycycline 100 milligrams in Acne Vulgaris. But in another study, the reduction in inflammatory lesions was not statistically significant. Sarecycline, we don't yet have in Canada. This product is a narrow spectrum tetracycline class antibiotic, less chance as far as an antibiotic of causing resistance. So if you feel that that person, you've tried other things and they really need a systemic antibiotic, which of course you likely use with benzoyl peroxide, then this might be a good choice because it has narrow spectrum. And it seems to be very well tolerated with same side effects as other tetracycline class antibiotics, but the rate of these side effects is actually seems to be quite low. Anti-androgens are increasingly being used to treat acne, especially since we're trying to limit antibiotic resistance. We have topicals, we have oral contraceptives, spironolactone, and there's some other anti-androgens, which I'll briefly discuss. Currently, we do not have any topicals, but this topical Clascoterone is really exciting when we will get it. It's expected that we should get it in the near future. And the neat thing is it's the first anti-androgen that males can use in acne because there's almost no systemic absorption with this product. So in the past, as females, we were lucky that females could use anti-androgens. They could go on the oral contraceptives. They could take spironolactone. But males often, if they use these products, you know, they might get breasts, and most males do not want to have gynecomastia. So topical Clascoterone is actually a potent androgen receptor inhibitor. It competes with DHT for the receptor. It's a 1% cream. It's once a day, and we know that when you use things once a day versus several times a day, adherence really increases. So it will be nice to have this product, which, as I mentioned before, can be used not only in women, but also in men. This is just showing you a study where there was a 65% reduction in total lesion count, but the gray with the black, which is the Clascoterone. But if you look at vitamin A acid, which is the gray line bar, you can see here that it was better than vitamin A acid at all time points, although it was only statistically significant at week 6. However, when you compared vitamin A acid to placebo, at any time point, even though numerically vitamin A acid was superior, statistically it was not. Oral contraceptives have been used for years to help treat acne. We have several approved. The nice thing now with oral contraceptives, we don't have to do pelvic exams. We don't have to do pap tests before ordering them, which means that I think that was a limiting factor for many dermatologists. People weren't comfortable doing bimanual examinations, and typically we don't do pap tests in the office. So it's nice now that those are not felt to be requirements for prescribing oral contraceptives. Here are a number of them. There are several generics as well, as you can see on the list. So we have a very rich group of oral contraceptives that should help our acne patients. They're indicated for acne for all severities, mild, moderate, or severe. They contain estrogen and progesterone typically, and they increase estrogen levels and decrease free testosterone and androgen levels in both ovaries and sebaceous glands. Now, the progestins can be androgenic, meaning that they might make acne worse, or they can be anti-androgenic. And drospiridone is a 4th generation progestin, which is more similar to progesterone. One of the things we hear about and we're concerned about when we order or prescribe oral contraceptives is, well, what about if somebody gets a blood clot? You know, do I really want to be looking after that? So I thought I would just show you the relative risk of getting a blood clot. So if you look at the non-users at the very top, it's about 2 per 10,000 can get a blood clot. If you look at an oral hormonal therapy, it raises to about 6. And if you look at pregnancy, it's 29. So about 5 times as high a risk being pregnant versus being on an oral contraceptive. But immediately postpartum, the risk increases to 300 to 400 per 10,000. So just to put it into perspective, you know, if somebody gets pregnant, you know, because these oral contraceptives are extremely efficacious as far as preventing unwanted pregnancies. If somebody should get pregnant, then they have a higher risk of having a VTE. Spironolactone, if you haven't used it, I would really urge you to consider using it. I didn't use that much before we were all concerned about antibiotic resistance. We did use a lot of antibiotics, as Chuck stated, but spironolactone, well tolerated, easy to prescribe, and I've been extremely pleasantly surprised with how well my patients do on spironolactone. It is not approved for acne in Canada. Now, spironolactone was first developed 64 years ago, so it's been around for years and years. It's a water pill, a diuretic, but it's also a synthetic 17-lactone steroid. So it is a steroid, and it inhibits androgen receptors. So that's how it works. You know, people go like, how does a water pill work in acne? But if you know that it's a steroid, then that makes a lot more sense. So there was a study looking at 200 milligrams of spironolactone. I don't usually go that high, and it decreased inflammatory lesion counts, 100 milligrams or less, you have better tolerability, and 100 milligrams or less usually works very nicely. What do you get when you order it? Because I think it's important when you're ordering something to be aware of it. You can have, breakthrough bleeding. Sometimes people will have breast tenderness. I used to monitor potassium because it does tend to retain potassium. I used to monitor on people, but it's no longer necessary unless perhaps if somebody had renal failure where their potassium might be high in the first place, would you have to do it. So for most people who are healthy, especially our acne population, monitoring potassium is not necessary. Chuck was telling me earlier on, he had one patient whose magnesium dropped probably through the diuresis. So, if the person is really feeling poor, if they're feeling sick and listless and, muscle aches and not feeling well at all, and they're on spironolactone, it might be worthwhile getting a magnesium level. The other thing, as I mentioned, the breast tenderness some people get, most people have nothing. So if you use 100 milligrams or less, most people have nothing. The big concern is feminization of a male fetus. So the external genitalia, if they're exposed to an anti-androgen, they look like feminine external genitalia, which people don't like to have a baby boy with without male genitalia. And so there was a retrospective study in young individuals, females ages 14 to 20. And the reason for females was, again, it's an anti-androgen. And if you gave it to males, you might get breast enlargement, which would not be a very popular side effect for them. And they looked at people who'd been on it for acne for at least 3 months in doses of 25 to 200 milligrams, the mean dose being 100 milligrams. And in this population, almost all of them were unresponsive to previous oral therapy, which for the most part was oral antibiotics. So again, whether it was antibiotic resistance or whether it was just really tough acne, because their patients were either moderate or severe being grade 4. And if you looked at the grade 4 group, which was about 3/4 of their population, 80% of them had improvement. You can see that roughly 2/3 of them were just on spironolactone by itself. If you do use it with an oral contraceptive, you get better efficacy. And the people who did the best were those who used it with an oral contraceptive, those who often have what they call hormonal acne, where you have jawline involvement and cyclic flares. So this might be a very good choice for them. So this is what I would recommend. Again, off-label. So we also have flutamide, which has been studied, but you need to monitor liver function tests every 2 weeks because of hepatotoxicity. So this really is not something that is widely used. This is exciting, actually, to me, this nanosecond pulsed electric field. So if you look at lasers in IPL, PDT, I think we all have patients who've been treated with these various modalities, and some patients seem to have done quite well. But a Cochrane review basically said that high quality evidence for light therapies in acne is lacking. We need more studies. The AAD guidelines felt that PDT had the best evidence, but again, came up with the same conclusion, more studies needed. What is really exciting is that for those of you who get the Derm Times of Canada on the front page, you'll see in the recent edition, the nanosecond pulsed electric field therapy. So these are pulses of ultra-fast non-thermal energy. They alter internal organelles such as the mitochondria and the endoplasmic reticulum, but they don't disrupt cell membranes. They actually physically kill C. acnes, so this doesn't lead to genetic resistance, although unfortunately to date with what is used, we don't get 100% killing. So it's currently not used as monotherapy, but as the procedure becomes more advanced, then this may be something that is going to become widely used. C. acnes can create a biofilm, making penetration of our treatments difficult, and this can alter the biofilm, making our treatments more effective. There's also lysozyme that has been used to pre-treat people before they have this nanosecond pulsed electric fields. And this weakens the cell walls and has made the C. acnes more vulnerable to the therapy. So stay tuned. This is something that looks sort of exciting for the future. And finally, we have what I call the pot of gold. Like for 40 years, more or less, we've had isotretinoin, and it has transformed the lives of many of our patients. Initially, we had Accutane, then we had Claris, then we had Epuris, and in Canada. And me personally, I tend to use Epuris because I know exactly what they're getting, and many of my female acne patients are often dieting. I tend to find that a lot of the fellows tend to eat you out of house and home, but a lot of the women tend to be dieting. Some of them have, unfortunately, eating disorders, and they don't eat a lot of fat. So you need fat. It's a fat-soluble vitamin. So for optimal absorption of the older versions, you need fat. So I tend to order Epuris. Now, Chuck, what do you order? Do you order all of them, or do you have a favorite isotretinoin brand?
Oh, I think that Dr. Lynn is muted.
I think you have to unmute
There,
yourself.
okay.
There he is.
Again.
I'm off there now. Yeah, I tend to primarily use Epuris as my isotretinoin of choice, just as you said, Lynn, for the better absorption and everything else. Where I use Accutane is where it's very interesting. I've been in practice since 1983. I have a number of people, and they have the parents now bringing in their kids, and I want my kid to go on Accutane because you did such a great job with the Accutane before. It helped me so much. I want my kid to do this. I do try to tell them that we now have a better drug, but many of them sometimes still go, no, I want the Accutane. But for the most part, it's Epuris.
Yeah, sometimes if somebody has been started by somebody else and then they've moved to London to go to university or college, then they've been doing quite well with another brand, then I will continue them on the brand if they're doing well and there's no reason to switch them. So why is it a pot of gold? Well, it's the only product that can actually put the disease into remission. It also affects all the various mechanisms that result in acne. So what exactly is it? It uses this Lidose technology. As I mentioned, isotretinoin, it comes from vitamin A. It actually is a naturally occurring 13 cyst. All of us have this in our bodies, but in much lower concentrations than what we're doing when we're prescribing these medications. So you need fat to make it absorbed. Oral absorption is enhanced, like it's doubled if you give it with a fat meal. And what it does with this technology is it embeds the isotretinoin in a lipid matrix. So you get much better absorption, especially if the person is not eating. For those of you who may not be familiar with this product, Accutane, you have 40 milligrams and 10 milligrams. This also has a 10, 20, 30, 40. So you have more options for dosing. So we were involved with this study looking at bioequivalence to the Accutane version. And in the study that we did, this helped lead to the drug being approved. It was looking at taking it with food, because we know it really wouldn't be fair if you said, okay, well, we know that Accutane doesn't get absorbed, but Epuris does. So we were like, okay, well, we're going to put them on equal footing. So they both took them with food. And I will show you some results of how similar the results are. But if you actually look on the graph to the right-hand side, you will see that this is the Accutane brand, this is the Epuris brand. You're getting roughly a doubling of how much Epuris is actually the peak, and the whole area under the curve is about 85% greater. So it really is good, particularly for people who have erratic eating. And even though fellows often eat a lot, they don't always graze throughout the day. So they may not have a fatty meal and may take it on an empty stomach and not have nearly as great absorption as you would like. So this is what we're talking about. You really want a high-fat meal. And studies have shown that about a third of adolescents actually skip breakfast. and a quarter consume ready-to-eat cereals, so there's less dietary fat. So it is a fat-soluble vitamin, vitamin A acid, and the retinoids, so taking them with fat will increase absorption. Less of a problem with Epuris brand. So this is looking at, you know, how similar were they? So this is looking at taking it both with food, because it really wouldn't be fair if one was on empty stomach and one was food, because we do know that isotretinoin acne brand has to be taken with food. And you can see that the lines are almost superimposed on each other. This is as observed. This is last observation carried forward again, almost one on top of the other. The reduction of nodular counts, no statistical difference between them. So in summary, if you haven't used this brand, the one thing is you're not getting any substitution because there currently is not a generic. It is covered on Ontario drug benefits for those of you who practice in Ontario, and it's reliably absorbed in whether you're eating or not eating. And compared to Accutane, if you are fasting, you get much better, much greater absorption. The efficacy and safety profile when you are taking it with bed conditions, almost identical to the Accutane brand. And there are 4 strengths, so you've got 10, 20, 30, and 40. So what are our options? What's in our toolbox? We have topicals. I think the red, we're trying not to use antibiotics by themselves. If you use it with benzoyl peroxide, it shouldn't be a problem with, shouldn't have a problem with antibiotic resistance. So you can use antibiotics as long as you use them with benzoyl peroxide. By acne for 16 weeks, they didn't have antibiotic resistance, but many of the physicians treating acne have concerns that you might get antibiotics resistance after the 16 weeks if you use it on a prolonged basis, because retinoids do not kill bacteria. Dapsone is not being associated with C. acnes resistance, and then we have azelaic acid, as well as many combination therapies. When we're looking at systemic antibiotics, as you've heard several times tonight, is we really want to limit use to 3 to 4 months maximum. When you're using them, use them with topical benzoyl peroxide, which could be a wash or a leave-on product. And then sub-antimicrobial doxycycline has also been used, and Sarecycline, which is a new antibiotic that is not yet in Canada, but soon she'll be arriving, might be a better choice when you're trying to pick an antibiotic if you feel that those patients with their inflammatory lesions really need to be on an antibiotic, systemic antibiotic, to control them. And then we have the anti-androgens, not only the oral contraceptives. And again, a reminder, you don't have to do pelvic exams. You don't have to do pap tests when you initiate them. So I think that should make more of the physicians treating acne more comfortable. If you have not used spironolactone, in the 100 milligrams or less, it's extremely well tolerated. I would really strongly encourage you to use it. And many times where I was going to reach for an antibiotic, I now can go to spironolactone and keep these patients on very good therapy. It works better if you use it with oral contraceptives, but many patients can be on it by itself or with a topical agent and do very well for a long period of time. The topical Clascoterone, which is a topical anti-androgen, we look forward to having that. Its big advantage is it's the first anti-androgen that we can actually use in males with acne. Lasers, we do have some interesting nanosecond pulsed electric field therapy, which looks promising, but for all of the lasers, we really do need some more studies. And I think isotretinoin, even though it's been around for 40 years, nothing has come to beat it. We still find it's the only one that can put acne into a prolonged remission, and it affects all of the mechanisms in the pathogenesis of acne. Thank you. So Chuck and I were happy to receive your questions or comments. Here are emails if you need to get a hold of us. And I think we'll take some questions now.
Absolutely. We'd still like to thank our sponsor, Cypher, for making this educational event possible.
And we do have time for questions. So a question, I guess, for Dr. Gunther, how do you prescribe spironolactone?
So spironolactone is a water pill, and I used to be cautious and start at 25 milligrams. In Canada, we have a 25 and 100 milligram. And what I find is 100 milligrams is very well tolerated. Most people don't have breakthrough bleeding, especially if they're on an oral contraceptive. So I usually start with 100 milligrams. I did potassium levels on everybody. I no longer do. If somebody has kidney problems, then I would probably do a potassium level, and then Chuck's case of the magnesium, if somebody's not feeling well, you maybe want to expand in that case, Chuck.
Yeah, it's, I must admit I had a case where the magnesium was low, and it was really, I had already checked the potassium. It was okay. The patient was feeling unwell, and I thought, oh, maybe I better check the magnesium. And I looked up in the monograph, and actually it says that in the monograph that it can be. So it was a learning point for me. This happened several years ago. When you talk to doctors, dermatologists, we all have little different opinions. I must admit, I start a little bit more cautiously with the spironolactone, particularly in a very skinny female, low weight, because you can sometimes drop the blood pressure. I've had that a few times where people feel a little bit dizzy. But most of our people that have, say, PCOS, Lynn's quite correct, they're overweight, and you don't have that problem. But I'm sometimes a little more cautious. But 100 milligrams is my sort of point. I rarely go to 200, and I've got one person I think on 300, but she's quite heavy too.
Yes, I think some of our acne people, especially if they're younger, I agree that a lower dose would be an appropriate starting point.
One question is, how do you prescribe isotretinoin? 120 milligrams per kilogram accumulative dose, or 150 milligram or low dose isotretinoin till 2 months after last pimple? No accumulative dose.
Lynn, what do you want to do? You want to take that one, or shall I?
You can start, because that's fine.
Yeah, okay. So, back in the day when isotretinoin was being developed, about 1982, it came on the market in Canada. I think it was 81 in the United States, or it was 82 and 83, right somewhere around that time period. Those studies that were done at that time, they basically pulled it out of the hat. They had noticed, and they did the statistics. And once you got to about 120 milligrams per kilogram, that seemed to be, typically that was achieved for most people somewhere between 4 to 6 months. I must believe that, and I think most dermatologists have a different philosophy now. You basically go until they're clear, and go maybe for a month or two afterwards. For most of my patients, that means they're on 5 or 6 months. I've also learned that lower dose, as in usually about 0.5 milligrams per kilogram, is where I'm using most of my isotretinoin. There's no need. The Germans in the day used to do it at 1 milligram per kilogram, and we're going to get you all better very quickly, and they got more side effects. At a dose of 0.5 milligram per kilogram, you get the dry lips, you might get some dryness of the skin, occasionally a nosebleed, but most of the other things don't occur. And so I just go a little bit longer, and I basically see my patients usually every 2 or 3 months, evaluate them, and go, okay, you're still getting some, we're going to go another month or two. I go until their thing. And then basically, if you've got a patient that maybe has had one, cleared quite well, essentially I'm basically promised my patients after kind of 6 months or so, 100% of people are going to be clear with isotretinoin. There are people that get their breakthrough with their acne subsequently. Those people, I might then treat them, the regular dosing, and then put them on a maintenance dose of low dose, particularly if they are very oily, and if they're really, that's the thing they're bothered by afterwards. Lynn, how do you do it?
I trained in the US, so I have a little bit different perspective, because they tend to be more litigious in the US. I trained at the University of Michigan. So I do monthly pregnancy tests still on the females, and they don't get their next prescription. It's not like the iPledge, but sort of my Canadian version of iPledge. At least I know they're not pregnant when they are getting their next dose. Males, if some of them can have very high cholesterol and triglycerides. Triglycerides tend to be more, I think, related to drinking. So, but you can get pancreatitis if they get to be quite high. So, people are doing sort of for the first 2 months, maybe 3 months checking. If they're stable, then you probably don't need to follow the blood work. But I still follow the females just because I don't want any of them to get pregnant. And the other thing is I do use retinoids. So after somebody has finished their course, I will, if they were on TAC2 pump, which also has a benzoyl peroxide, I use what they have at home. If they have, let's say they were on vitamin A acid or some of the newer retinoids that we now have, then I get them to pull that out, and that's what they go on after they've had their acne. And the advantage of that is the retinoids also help with the post-inflammatory hyperpigmentation. If you have superficial scarring, that might cause a bit of collagen deposition. You might minimize some of the scarring for your acne patients. So generally a week after you stop isotretinoin, all of your mucocutaneous side effects end, and then you can add a topical retinoid. And many of them are able to tolerate it. I think after they've been dry with isotretinoin, the topical retinoid doesn't seem quite so drying. But the flares also sometimes occur. If you've got a really like an acne fulminans or terrible acne, then I might consider starting them with 10 milligrams just so they won't have a horrific flare. And I typically will give them prednisone as well.
Yep, I'm in quite agreement with you, Lynn. I think using a retinoid afterwards gives you a fair amount of remodeling of the skin. I've had a number of people go, okay, so you told me, Dr. Lynn, plan A is to get rid of that acne. We've done that, and plan B was to make my scars go away or minimize those. And I usually say, fine, let's try a retinoid on an ongoing basis. I think you're going to get remodeling. Certainly it decreases the post-inflammatory hyperpigmentation. And a number of those ones where we talked about potentially having to use a laser, they go, oh, I don't need this. My skin is fantastic, Dr. Lynn. So I'm in quite agreement using a topical retinoid afterwards. And we luckily have a number of different ones that you might use.
Mm-hmm. And many of them have been on one before they start. So this is, they can go back to what they have at home.
So another spironolactone question, how soon would you notice the benefit?
It's often a few months to notice a difference with spironolactone, but I see people every 3 months. I guess we're fairly busy, so I used to see them at a month initially, and then I saw them 2 months for several years, but now it's 3 months just because there's a big volume and more people who've retired. So we have a large volume of people to see. So I see them at 3 months, and the nice advantage of that is you expect to see some difference. If you see them at a month and they're not better, because a month, if your skin turns over, it takes about a month for your skin to turn over. So I tell patients that right off the bat with acne, and I think this is a critical thing to tell all your acne patients when you first start seeing them for acne, that your skin cycle is about a month, and it often takes 2 to 3 months to notice improvement. Now we know benzoyl peroxide, often 2 weeks you'll see improvement. But if the patient thinks it's going to be, this is the art of medicine, if they think it's going to be a few months to get better, and at 2 weeks they've noticed something, they're ecstatic. Usually at 2 weeks, if they haven't seen anything, you didn't tell them something, they stop that product and come back in and say, that product you gave me does not work. I want something else. And if you say to them, oh, you didn't use it long enough, they don't really care. They've already X'd that product and they're not going to go back and try it.
Lynn, excellent teaching point. I remember that I was taught in dermatology residency, bring them back a little sooner, that increases the adherence or compliance, or whatever you want to call it. But if you bring them back too soon, oh, come on, it's not best yet. And you all of a sudden ran out of options because you were changing every time. And so I agree, setting up the expectation that they're going to have a 2 or 3 month thing before they're going to be better. limits you having to switch from thing to thing and run out of options eventually.
We have lots of options, as you can see from what I showed you, but we do run out of them. People have tried most of these things often by the time they come and see us, and it makes it difficult and challenging trying to offer them something new.
Another question, drospirenone containing oral contraceptives with spironolactone. Any concerns with potassium? Should we monitor?
Okay, that's something that the pharmacists come and tell you because it's you know, they go, oh, you have to be monitoring their potassium. So when I first heard this, I thought, okay, well, we'll monitor the potassium. So there I was back again monitoring everybody's potassium. I have yet to have a potassium go up. So I do tell patients it may go up, but it has not. I have not seen it. Have you seen it with? It's reported, and so the pharmacists, some pharmacists get all excited.
It's extremely rare, and actually there's been a number of acne papers and physician papers. It's not a problem. In fact, it's a good combination.
Yeah, no, it actually works extremely well, especially for jawline acne, cyclical acne, very good combination. But sometimes if somebody can't take an oral contraceptive, as long as you feel that they're not going to get pregnant, because you don't, the male genitalia actually develop fairly early, so often before they might realize that they're pregnant. So I think you want to make sure somebody who is sexually active that they do have protection so that they don't inadvertently get pregnant and have a male fetus that with female genitalia.
Yeah, Lynn, actually, I do a fair amount of CMPA work. It's a theoretical problem. In fact, there has been no cases of feminization of a male fetus. It's theoretical, and I'd still be careful, but there really haven't been. So,
you know, but I think spironolactone wasn't that widely used. Like it's only recently
fair enough.
Antibiotic resistance, so that might change. You know, because the era is changing.
One question is, why can't we get topical erythromycin anymore? It was effective for my patients.
Yeah, I'll take that one. Yeah, it's not going to be effective anymore. Essentially almost 100% of C. acnes is resistant now to topical erythromycin, and that's why it was pulled by the companies. Not being beneficial. So yeah, you can't get it anymore. And I mean, you can make it up, I guess, but part of the thing we were telling you tonight, beware of antibiotic resistance, particularly in these topicals. So if you're going to use a topical antibiotic, use it in conjunction with a benzoyl peroxide.
So we've shown you a number of different products that it's not like there's only a couple of things that you can give your patients. We have many tools, and it's exciting that there are more and more products that are coming our way to treat acne. So we will still have a lot that we can offer our patients, even in this era of antibiotic resistance.
Now, one practical question. A lot of new topicals are not covered on ODB or NIHB. So what topical do you recommend that are covered? Because that's why we would get requests for topical antibiotics.
Well, unfortunately, we have basically vitamin A acid that's covered, like Steva cream, for example, in various concentrations is covered. We also have benzoyl peroxide clindamycin combinations, such as benzaclin or clindoxyl, that are covered. Now, azelaic acid is covered on ODSP, but its indication is 15%. It is meant for rosacea, but it is used off-label. And I have used it, especially if somebody has inflammatory acne and they also have a lot of pigmentary, post-inflammatory pigmentation, then I will use it because I find that it works quite well. I do tell them that you will probably find literature about rosacea when you look at this product. You do not have rosacea. You have Acne Vulgaris, and in the States, they have a formulation of this product that is approved to treat Acne Vulgaris. So I've never had anybody come back after I explain that, you know, saying like, why did you give me something for rosacea when I don't have rosacea? So I usually let them know that it's off.
Yeah, Lynn, in this era of everybody having to wear masks, I particularly find in this, whatever you call it, maskne, that Phoenicia is a good go-to drug. Not irritating to the skin, It's good for down around the chin area and the post-inflammatory changes. So you don't get foam backs, and they can wear it and wear their mask and not have a problem. So I agree with you.
We didn't talk about retinoids being teratogenic. I thought most people realize they are, certainly with oral isotretinoin. Everybody's aware about the pregnancy testing, but topical retinoids are considered, all retinoids, topical and oral, are considered teratogenic. Some have a harder labeling than others. So if somebody is get pregnant or contemplating pregnancy, it happened several years ago when I think there were 4 Australians who had vitamin A birth defects in children. And then all of a sudden, vitamin A acid, which we had commonly in the past used to treat pregnant women, we no longer do now because of these 4 people who had vitamin A birth defects, associated birth defects. But if with retinoids, you do have to make sure that they stop them if they're trying to get pregnant. Now, they're not to the point where I would recommend somebody have an abortion, you know, like with isotretinoin. I think we tend to be more concerned. Certainly the topicals, I don't think there probably is a huge concern except from a medical legal point of view, so we don't use them in people who are pregnant. However, Finacea is perfectly safe in pregnancy. So it's another, you know, if somebody, you know, we don't have a lot of drugs, so we have this clindoxil or benzaclin, which is clindamycin with benzoyl peroxide available as a topical on those drug plans that you talked about. But, you know, what do you do if they fail that or they can't tolerate it? It is nice to have azelaic acid as an option, and it is safe in pregnancy. Again, off-label.
I think it's a good point, Lynn. You know, the government only has X number. There are a few choices for your acne patients, right? So, and some people are benzoyl peroxide allergic. So that takes out the benzaclin and clindoxil. You're left with a topical retinoid such as Steva or the Finacea as your choices there. And sometimes you have to tell people they have to bite the bullet and maybe use another thing. And you may actually have samples. As dermatologists, we're sometimes fairly lucky to have enough samples that we can help people with.
Yeah, I mean, especially if they have comedonal acne, I think we're limited because we really want a retinoid.
Do you have any experience with azelaic acid in treating post-inflammatory hyperpigmentation?
Yes, I find it works extremely well, not just for acne, post-inflammatory hyperpigmentation, which is a major problem in particularly in individuals with more natural pigment in their skin. So people with skin of color, it's more of an issue. I trained in Michigan, half our patients were Black, and it was a major issue for the patients. At that point, we only had topical retinoids that we could offer as an alternative, but Finacea works extremely well. So even for melasma, I know we're talking about acne, but other pigmentary things for melasma, very well tolerated. I actually find it works better than a lot of our traditional treatments that we have used. So hydroquinone and you know, even like glycolic acid, I find that I've been having very good success using azelaic acid, the Finacea brand, for these individuals. And it is approved for rosacea, and those rosacea patients have sensitive skin. So usually it's tolerated by most people.
So as a last question for this evening, based on your talk tonight, why does topical clindamycin even exist on the market?
Good point. Shouldn't. So there's, hopefully you guys, if you were ordering it before you came to the talk, you'll stop ordering it. And then if the companies that are making it, because there's a couple there, as you saw, don't get enough orders, maybe they'll just stop having them available. So please be stewards of antibiotics and recommend, you know, if you were using a lot of Dalacin tea, please consider not using it, and tell your friends not to use it as well. If you're going to use clindamycin, use it with benzoyl peroxide.
Well, that concludes our evening. Thank you to Dr. Gunther and Dr. Lynn for such a thorough and really clinically practical presentation this evening. And thank you all for joining us. We truly appreciate your interest and your support. Good evening, everybody.
Night.
Good
Have a
night.
good one. Bye-bye. Thanks,
Bye-bye.
Lynn. Thanks, Roxanne.
Thanks, Chuck.
Bye.
Thanks, Roxanne.